So I had the pleasure of presenting a phase 1b, phase 2 open-label, multi-center dose escalation and dose expansion study that evaluated the combination of atirmociclib, a next-generation CDK4 selective inhibitor, in combination with PF07104091, which is a next-generation CDK2 selective inhibitor, in combination with endocrine therapy in patients with metastatic breast cancer and other solid tumors. So the background to this is that CDK4/6 inhibitors combined with endocrine therapy have improved survival outcomes in patients with HR positive, HER2 negative metastatic breast cancer. However, on-target toxicities is common with these drugs, and resistance can occur through RB1 loss or cyclin E1 upregulation that leads to subsequent activation of CDK2. Atirmociclib is, as mentioned, a selective CDK4 inhibitor with significant sparing of CDK6 that is associated with less neutropenia than the approved CDK4/6 inhibitors. In comparison, 4091 is a first-in-class selective CDK2 inhibitor that's also being investigated in HR-positive metastatic breast cancer. And therefore, the combination of both the atirmociclib, the CDK4 selective inhibitor, plus 4091, the CDK2 selective inhibitor, plus endocrine therapy may overcome this resistance to prior CDK4/6 inhibitors and provided the rationale for us to proceed to this phase 1/2 trial. So I presented data from the dose escalation phase of the trial. The primary objective was safety and tolerability. Secondary objectives were antitumor activity and pharmacokinetics. In terms of the safety profile, the combination was manageable, safe, and well tolerated, especially at the 2 recommended doses for expansion. The main side effects observed included neutropenia, anemia, fatigue, and GI toxicities. Overall, there were no DLTs observed at the 2 recommended doses for expansion, and we're currently expanding at both doses. Pharmacokinetic data showed no obvious drug-drug interactions, and steady-state exposures were comparable to monotherapy. In terms of pharmacodynamics, the combination led to modulation of pharmacodynamic biomarkers. There was an early decrease in ctDNA levels at cycle 1, day 15. We also observed decreases in phospho-RB, Ki67, and FOXM1. There was promising antitumor activity seen in these heavily pretreated metastatic breast cancer patients treated with CDK4/6 inhibitors. Out of 18 patients with RECIST measurable disease, the objective response rate was 27.8%. The disease control rate was 55.6%. Importantly, all of the patients who achieved a partial response by RECIST criteria had ESR1 mutations. 3 of them had prior chemotherapy drugs, and 2 of them had PI3K pathway alterations as well. There was promising, durable activity observed as well. The clinical benefit rate was 50%. The median progression-free survival was 8.3 months, and it's very heavily pretreated patient population. Median line of prior therapies was 3, and some patients received up to 14 lines of prior therapies. So overall, the combination of atirmociclib, a next-generation CDK4 selective inhibitor, a significant sparing of CDK6, plus the combination with a next-generation CDK2 inhibitor, PF07104091, had a manageable safety profile and was well tolerated at both recommended doses for expansions that were selected. Antitumor activity with an overall response rate of 27.8% was observed with this combination in heavily pretreated metastatic breast cancer patients with prior CDK4/6 inhibitor exposure, including patients with ESR1 mutations. Dose expansions of this combination plus endocrine therapy are currently ongoing for CDK4/6 inhibitor treated or naive patients with metastatic breast cancer.